To all who are new here, welcome to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our upcoming schedule, so check back often. For all athletic trainers who are intending to get CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You'll have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. 2 articles related to today's talk are available for download from the dashboard. If you have difficulties downloading those articles, which we have received a notification that there was, please email us at journalclub@relevesportsmedicine.com if you would like to get access to that article. Otherwise, we will also include it in our follow-up email that we'll send out in a few days. The recording will be available for review from our website tomorrow. I'm pleased to present our speaker tonight, Dr. Brandi Cole. She is a sport and exercise medicine physician specialist who completed her fellowship at the Australasian College of Sport and Exercise Physicians in 2019. She completed her medical degree at the University of Sydney in 2008. Prior to that, she completed her undergraduate degree in physiotherapy from Sydney University in 2003. During her specialist training in sport and exercise medicine, Dr. Cole also completed a PhD on optimizing the management of rotator cuff dysfunction through the University of New South Wales in 2018. Dr. Cole is the current team doctor for the Junior Matildas football in the United States soccer team and the Sydney Roosters National Rugby League football team. She is the touring team physician with Australian OzTag and has provided medical coverage at major Australian CrossFit Championships since 2012. She has previously provided medical services at many high-level sporting events, including athletics at the 2018 Commonwealth Games and the 2015 Netball World Cup. Dr. Cole has personal experience as an elite athlete, being the former captain of the Australian Women's OzTag team, of which she was a member from 2001 through 2017. She has also played both touch and hockey for her state in the past and was an Australian and world gold medalist in beach sprint relay in surf life saving. Dr. Cole is a mother of 2 children, an 8-year-old son and a 3-year-old daughter, and she has a special interest in exercise for health during pregnancy and the postpartum period, for both recreational and elite athletes. She is speaking this evening about keeping active during and after pregnancy. And I'm going to go ahead and transition the slide to her. We'll let you take it away, Dr. Cole.
Thank you very much for that introduction. I just want to check that you can hear me.
Yes, we can.
And you can see my slides.
Yes.
And my apologies that my webcam is not working and you can't see me, although that probably makes it a better experience for you all. And in saying that, there's some pictures and videos of me in my slides so you can get an idea of who's talking. I'll try not to talk too quickly. I have a bad habit of doing that. Plus you have to translate the Australian accent, so I'll do my best. very daunting talking to a crowd that I can't see. I'm literally talking to myself into my computer, and I have no idea whether you're still there or not, but I'll go ahead anyway. So today we're going to spend just under an hour talking about how to keep pregnant women active during and after their pregnancy. And this is a big, broad spectrum of women who want to stay active and women who are scared about being active. In terms of my presentation, there's no conflicts of interest, and I do this for the love of it. So the presentation's in two parts, or the webinar's in two parts. The first part, we're going to focus on pregnancy, and the second part will focus on the postpartum period. But a lot of the themes are relevant through both phases of the childbirth cycle. The things to think about initially are, obviously, the pregnant woman is worried about the effects of exercise on her fetus, and then also on her own body. And then in the postpartum period, obviously the baby is now detached from the mother. So the mother is more just concerned with getting over the effects of childbirth and the effects to her own health. So some of you may not have been pregnant before or had children. So we're just going to run through what it's like. And there's some little anecdotes for me. I'll give you a disclaimer now that I didn't really enjoy being pregnant, although I didn't really have any complications. So I've no reason to whinge, except that I just wanted to have it done straight away, although then you enter the phase with the newborn, and that brings its own challenges. So we divide pregnancy up into trimesters. So the first one traditionally ends around the 12 to 14 week mark, although really it's only 8 weeks, because you count from the day of your last menstrual period, and conception actually happens 2 weeks later. And so even though we talk about pregnancy being 40 weeks, it's really only 38, and you don't often find out you're pregnant until at least 4 weeks, which is another 2 weeks later. So from the day you find out you're pregnant, somewhere between 4 to 6 weeks, the 12 weeks is actually the shortest trimester, because it's really only 8 weeks, but it absolutely feels like the longest, often because you're trying to keep it secret, and you feel it's quite amazing how many changes happen in this first period, even though physically you probably don't look any different. So there's certainly things to focus on in terms of the ligament laxity from the relaxin actually peaks at the end of this trimester, even though, as I said, you might not physically notice that a woman's pregnant, she will certainly feel pregnant. And nausea and fatigue are major barriers. I remember in my first pregnancy, I didn't think I was nauseous or had any fatigue, but when I hit the 14-week mark and I started to feel better, I realized how bad I had been feeling. So there's lots of things that you need to take into account if you're training a woman in the early days of her pregnancy, because she might feel like it's a cop-out that, oh, I'm pregnant, but it shouldn't be feeling this bad. But in actual fact, it can feel worse than the middle part. And we'll get more into it a bit later about the important things in terms of modifications and things to look out for. The middle, the second trimester, I call it the honeymoon stage, because it really is when you start to feel a bit more normal again. The initial symptoms of pregnancy reduce. You start to get a little bump, but it's not really that bothersome physically. So you feel like you're validated as a pregnant woman, but it's not really impacting you too much. And really the only part of this middle phase is to consider is whether exercising on your back is appropriate or not, and we'll go more into that later on as well. And then the third trimester, and this is me here at about 36 weeks, I think. You really do start to notice the physical fatigue of having that belly, and more importantly, it's a physical imposition. So even just things like I remember working as a waitress during my first pregnancy and thinking that I could just squeeze into a gap, and I literally couldn't fit, or I closed doors on myself because I didn't realize my belly stuck out so far. So things are going to be more difficult even for very experienced athletes, because your center of gravity is so different that even the way that you move and how you're used to moving, you have to adjust for that. But it can be done, and certainly it creeps up slowly, so you've got plenty of time to adjust. And certainly I think that you're physically more impaired than So if you want to exercise heavily, I think your body impairs you more than you could ever put yourself at risk. So this is just to prove that there's no time you need to stop exercising. This was me, my daughter, I was being induced. So I had arrive at the hospital at 10 a.m. and this was me doing some squats before I went in. So this was literally the day that I had my daughter, and certainly there was no problems from training. And for me, that's a very light load. This is in my garage. So it was just something to keep me mentally and physically sane, because I knew I was going to sit in a hospital room all day, and that's certainly not something that I like doing. So now we look at the changes during pregnancy. It's, as I alluded to before, there's lots of changes and they start very early. So I say this to all the women that I treat or work with, is that people get so worried about if they're doing something wrong by their baby, their growing baby, but really our body is designed to protect that baby at all costs. So your body will starve you to support your child. So the saying at the bottom there, women are great mothers right from the start, is so true, that our body is designed to protect and support the growing fetus at all costs, even to the young woman. So really, when we're looking at things, we're looking at it from the point of view of protecting the mother so that she can do the good job of protecting her baby, because the protection of the fetus will come naturally. So there's lots of changes to the cardiovascular and the respiratory system. And the most important thing to get a hold of is that your resting, or the woman's resting heart rate, is going to go up straight away. So as soon as you're pregnant, your resting heart rate goes up 15 to 20 beats per minute. And I know a lot of women concentrate on what should my heart rate be when I exercise, but realistically, if you think about the fact that your resting heart rate goes up and that the fitter you are, the higher the closer to your maximal heart rate you get when you exercise. If you use heart rate as a guide, as a sole guide to exercise intensity, then you're actually not going to be able to do much at all. To be honest, my heart rate would spike the second I walked upstairs. So if I tried to use my heart rate to monitor what I did, then I probably would have been too sedentary, and that would have come with a whole lot of problems. Things like the hormones are decreasing your peripheral resistance, so your blood pressure will decrease and your heart rate goes up. So it's not really conducive to being the best athlete initially, especially since that your blood volume needs to almost double, not quite. But initially what happens is you get the fluid part of the blood volume increasing before the red cells increase, because it takes a little bit of time for the red cells to be made and respond to the EPO and be made. And so initially we have a dilutional anemia. And you actually can really feel that. So I definitely noticed the effects of, I'm someone who's, if I train normally, my muscles will give up before my sort of cardiovascular system will, but I noticed that I was really puffed doing simple things that I wouldn't normally be initially, and then that definitely improved as the pregnancy went on. And it's interesting because the respiratory system adapts to get you more oxygen, and your breath size increases, but not your rate. But you actually feel puffed more because of the physical imposition to the change that's happening. And interestingly, your ribs move outwards. And this is one of the things that I noticed the most, that they didn't move back in for me. So my whole physical structure changed in my first pregnancy. So sometimes you can change everything about you physically and it won't necessarily spring back, but it doesn't mean that that's a problem at all. And then in the musculoskeletal system, we know to think about the ligament laxity, the center of gravity, the strain on the pelvic floor, and the thinning and the widening of the linea alba. And these are normal things that need to happen to support the growing fetus, but each of these on their own can lead to problems. And it's a very individualized thing. So it's not a one-stop shop of, yep, this happens and then that leads to this. Some people tolerate these changes really well. Some people feel better. I actually felt better squatting because I'm normally very stiff, that I felt like this change to my center of gravity actually made it helped. It was very helpful for me in certain movements and a hindrance in others. So if we move on now to more specifically about exercise in pregnancy, these are actually, the World Health Organization has literally just updated their guidelines. So the 2020 guidelines have come out, and these are the guidelines for physical activity in general. And for the first time, they've included as a subset group pregnant and postpartum women, which I think is fantastic, because in the medical scenes, we've known for a very long time that it's not only is it safe to exercise in pregnancy, it's actually very important to do so. But I think that as with a lot of things, the medical world is leaps and bounds ahead of the general community. So the fact that you've got guidelines that you can draw on that says that women should be participating in regular physical activity throughout pregnancy and afterwards. And the actual guidelines are exactly the same as the general population. So 150 minutes of moderate intensity. So that's basically anything that you can still carry on a conversation. You can still say a sentence, but you might be lightly puffing. And that you should incorporate aerobic and resistance work, muscle strengthening activities, and some gentle stretching. And I think the other two things are that that you should actually limit being sedentary. There's actually no benefit in prescribing rest for a pregnant woman. And also that down the bottom, you can see that those who were formerly training in vigorous activity can continue those. So it's not like you have to just start doing brisk walking if you've been a marathon runner or a track and field athlete. These guidelines are for non-complicated pregnancy. So of course, with any guidelines, there always comes disclaimers and exceptions to guidelines, and we'll go through those now. Before we do, again, this is, I think this was my second pregnancy, and it was just something I actually documented on Instagram every day of my training through pregnancy, just to try and get some awareness of that was okay to move when you're pregnant. And this particular slide, it was interesting when people would comment. This particular one had a lot of sort of negative feedback of either, why on earth would you do this? Why don't you just rest? Because once you physically look this pregnant, people just think that you're strange to want to exercise. Or mixed with all sorts of, oh, you're going to do something with your abdominals, or you're going to harm your baby. And it's just a naive sort of opinion, because in actual fact, the days that I didn't exercise were the days that I felt the worst. My body ached, I was fatigued, it was very hard to get through a long day of consulting, but an hour of exercise on the way to work really helped me get through that day. We all know the benefits of exercise generally, and really they're not that different in pregnancy, except that there is actually a documented decreased risk of complications such as hypertension, preeclampsia, and also things like reduced rates of gestational diabetes and pregnancy weight gain, and then all the pain associated with it. And I definitely found that I suffered a lot of pelvic pubic symphysis and lower back pain during my pregnancy, and it was far worse on the rare days that I was sedentary than it was on the days that I was moving my body. In terms of, as I was saying before, there are some people who sit outside the norms of those guidelines. So there are some people that have to be careful about exercising during pregnancy. And the thing that I will say to this list here is, so it says absolute contraindications, as if like it would be disastrous if you were to move around. But in every one of these guidelines, it also says that women can continue their general activities of daily living, but not participate in any further exercise. And I find that interesting, because I think you'll find that a lot of women's normal activities of daily living, especially if they've got more like a child at home already, is probably more related to physical exertion than a lot of people's training. So what I mean by that is a woman will stay at home and think she's not exercising, but she'll clean the house, she'll pick the children up, she'll go and do the shopping, she'll carry the groceries from the supermarket to the car, but that doesn't count as exercise because it's not exercise, it's just life. And then someone will go to the gym and do a very cruisy walk on a treadmill and get told that they can't do that. So I'm not saying that to ignore these guidelines, but I'm just saying that even in our lives, we are actually physically active. So these things, the IUGR is intrauterine growth restriction. So if the fetus isn't growing as it should be, or your cervix isn't supporting the pregnancy, or there's a risk of premature labor. So essentially all of these things the woman will know about, because their obstetric provider should be well on top of that. So unless the first two apply to the woman, so if she's very got serious heart or lung disease prior to being pregnancy, then she will know that she was probably going to have to be careful through pregnancy. And then all of the other things are things related to pregnancy. But as I said, it's not like the woman's not going to know that she has this going on. Then we've got the relative contraindication. So these things are very individualized. So on a whole, exercise may not be in the best interest of every woman with this, but it doesn't necessarily mean that they can't exercise. And these are more things to, they're sort of on the same lines as the absolute contraindications, but a bit sort of toned down. So the first one is if you've got a history of things happening in your last pregnancy, but it's not actually happening this pregnancy, you probably need to be a little bit more cautious, but it doesn't necessarily mean, as I said, that you're confined to the couch, definitely not. And you can find all of these in those references that I've provided for you. So then there's the woman who has no complications whatsoever and is exercising, but then starts to feel a bit strange. So these are the things that we have to think about during exercise. So if a woman is has a non-complicated pregnancy, but then starts to become really dizzy or lightheaded during training, or has a severe chest pain, or has a really bad headache, or calf pain, or starts to get vaginal bleeding, or starts to get regular painful contractions. So they're not the Branxton Hicks type, because that's the type of contraction that you start to get towards late pregnancy. It's almost like a training contraction for your uterus. And that I often had those when I did things that would bend over, my uterus would get stimulated. That's fine, but it's the regular painful ones that are similar to labor that you should stop straight away. But I think that with this list, again, like, women are pretty sensible, and I think if you had any of these as a exercising pregnant woman, you wouldn't just push on through it. You would actually stop. So if you're training or talking to people who are pregnant and being active, then these are the things to watch out for. But again, it's not, some women get very anxious about, oh, do you think this is one of those things? And I think that you do know about it if it's something that you have to think about. So there are some activities that are to be avoided, and this is where I think the lines are a little bit blurred. Some of them are very obviously a yes or no thing, and some of them are a little bit, it's hard to sort of draw a black or white line. So what I mean by that is things with, there's a high risk of falling. So obviously if you're going to participate in horse racing, for instance, you're probably not going to do that when you're pregnant, just because it's something that you're probably putting yourself and your child at risk that's unnecessary. And I think the way that I explain that to pregnant women is you're about to become a mother, potentially for the first time. And if you can't modify your lifestyle to adapt to the needs of you and your child, then you're probably not ready to become a mother, because it's a huge thing to become. You can't be selfish when you become a mother. You have to put the needs of your child first when they're actually, a child. So I think it's good training to start that when they're a fetus. Things like the direct trauma to the abdominal wall, that's a bit of like, obviously you're not going to see a 36-week pregnant woman participating in a boxing match, but at the beginning, you get a lot of elite athletes, and they might be 9 or 10 weeks pregnant, and they've got some major competition and they want to continue. And for the most part, that's an educated discussion with them, and it's their choice, and they choose to take that risk, because the fetus isn't above the pelvis till about 12 weeks. So theoretically, it's being protected there anyway. But as I said earlier, it's often when you're feeling really awful and during pregnancy, so you might not be performing to your best anyway. I had a football grand final when I was 9 weeks pregnant, and ironically I was playing against my girlfriend who was also pregnant, and we both knew each other was pregnant, but the other members of the team didn't know. And it is mentally off-putting. Like, I didn't want to go in physically on her, but what was interesting was I didn't want to go and hurt her, but I wasn't concerned for myself, because I had control over my body and I knew what it felt like, and I knew that I was fine. But it's very different when you are putting someone else at risk and you don't have any control over that. So these are all the sorts of things to think about with these activities, because there are women who will play sports well into pregnancy that are on this list. And we certainly had a big case in Australia quite a few years ago about a netballer who wanted to play visibly pregnant, and the sport were going to not let her. And I think it went to court, and eventually she was allowed to play. But it's a very grey line when you're choosing. And I certainly know that at 18 weeks pregnant, I went to the snow and I chose not to snowboard. But the reason wasn't because I didn't think that the snowboarding would affect my fetus. it was because I couldn't control what everyone else in the snow was doing. And I thought, if someone crashes into me, and that could happen if you're just standing on the slopes, not even if you're actually moving, and that would, it would be similar to a car accident. And if I was to get placental disruption because I'd put myself in a position, then I thought that that was a risk that I wasn't willing to take because it was out of my control to prevent that. But then other things, I ended up hiking up the mountain instead to an elevation of 2,500, which I'll tell you in a second, you're not meant to exercise at either, but that was something that it was well within my control, and I was happy to do that. The physiological risk is a bit different. So definitely scuba diving, the fetus can't protect itself from the effects of the bend, so nitrogen, the bubbles dissociating in the bloodstream, so absolutely that's a no. And things like skydiving and hot yoga, I just don't think that it's necessary. It's only 9 months of your life. You can probably put those on hold. And then the altitude one is interesting, probably more for you guys in the US, because in Australia, we don't really have cities at altitude anyway. And so if you're going to altitude, it's literally just popping up to the top of a mountain and back down again. But it's very different for someone who lives at sea level and then wants to go and exercise at altitude. That's a very different scenario for someone who lives at altitude. So if you live at altitude and you're conditioned to altitude, then exercising there is fine. But if you are a sea level dweller who just goes on a holiday to altitude and wants to exercise, then you have to think about it, because it's to do with the oxygenation to you and the fetus. So then there's some specific considerations during exercise. It's interesting because the core temperature one, this is a big one that's got a lot of press lately. Well, I feel like it has. It's well known that if your core temperature sits above 39 degrees Celsius or 103 Fahrenheit for you guys for a long period of time, that there is a risk of neural tube defects, and that's only if that temperature is occurring during the formation of the neural tube, which is around 20 to 30 days after conception. So it's around weeks 5 to 7 of pregnancy. And what you'll see is that most women, a lot of women don't even know they're pregnant until they're 6 or 7 weeks pregnant. So you might have already had your neural tube, the fetus neural tube formed before you even realize you're pregnant. In saying that though, it's very hard to get your core temperature that high just due to exercise. So there's been lots of studies on women exercising at 60 to 70% of your VO2 max, and you don't get your temperature above 38 degrees. So in actual fact, it'd probably be more risky if you happen to get a febrile illness right at the time that your neural tube was forming rather than exercising, but it is something to think about. The other thing is along the exercise is that women know that they shouldn't get too hot. And then, so when they sweat, they worry and they think, oh, I'm sweating profusely, so therefore I must be too hot. But in actual fact, your thermoregulation improves, and so you actually sweat earlier. And the thing that other people don't think about is that evaporation of that sweat is the best way to actually cool your body temperature. So sweat is a good thing, and if it happens earlier and you're exercising in a fan, then you're actually doing a very good job of cooling yourself. So it's more about educating on more about the risks than just saying, oh, heat's bad and I can't get too hot. I spoke briefly on the supine position. So this is lying down to exercise. So theoretically, there's a risk of decreased venous return. You've got a growing lump in your abdomen, and if you lie on your back, that lump is positioned on top of the inferior vena cava, and so potentially if the lump is heavy enough and you lie there long enough, it might partially close that vena cava enough to reduce the blood return to the heart, which therefore reduces the afterload and the stroke volume, and that can potentially lead to symptomatic problems in the pregnant woman. This is one that I found very individual. So some women will just train all the way through in pregnancy on their back and have no idea what the fuss is about, and other women can't even lie on their back in bed. They know that the second that they roll over onto their back, they start to feel a bit funny in the head, and then they sleep on their side. So there's two ways to go around this. It's to monitor and watch and continue exercise on your back if you feel good, if the woman feels good, or to modify the exercise to things like, instead of bench press on flat, you can do a 45-degree incline bench press, or you can do things in sitting or standing, or you can do exercises in side lying. Me personally, I stopped benching towards the end of my pregnancy, not because I ever had symptoms, but just because my pelvis felt worse lying down. I felt much better having load through in sitting. I actually found sleeping at night one of the worst things I had to do in my day-to-day routine. Whereas my sister, who's just had a baby 8 weeks ago, was out benching me at 38 weeks pregnant. I literally had to take weights off the bar to bench with her. So everyone is very different. The one thing I would say though is if you've got pregnant women doing exercise in supine and they're doing a mild Valsalva, which you'll read about you're not supposed to do, if their belly is doming, and we'll go into that, that's an absolute no. So if they're exercising on their back, but they say, oh, I don't feel dizzy, but they're doing some weird thing with their abdomen where they've got a bit of separation and you can see the dome in the middle, then they should stop exercising in supine. But we'll go more into that a bit later. With nutrition, I think it's very important to talk to the women that you're dealing with, that they really do have to think of this the same way that they think of athletic competition, in terms of you have to fuel more. So a lot of, especially women who are very active and then they're reducing their levels of activity or their intensity of their activity, they feel like they shouldn't eat as much because they're not expending as much energy. But you're actually expending more energy just growing the baby. And so these numbers are suggested. So as you can see there, it's suggested that you increase, slightly in the first trimester, and then as the trimesters go on, more. But again, these are guidelines. And what's interesting about this is I think I probably doubled my food intake in the first trimester. I was literally having 6 huge meals a day because I was just so hungry I couldn't keep up with it. And by the third trimester, I just physically couldn't fit food in my stomach because I was so tight with the pregnancy taking up all the room, and I had the reflux. And so I think in a way it was great that I'd sort of got all that extra energy in early, because I went for days where I really couldn't eat enough even though I was trying. So it is an individualized thing, but I think the most important take home from this is you actually have to eat more. But it's not an excuse to just sit on the couch and eat donuts and pizza because, oh, well, I'm getting big anyway, which I hear a lot of women say. To me, you're growing a child, so it's the most important time to concentrate on your nutrition above all, because I'm a firm believer that nutrition is a big part of health in general. So why would you eat less nutritious foods when you're starting to develop a fetus from scratch, when you could actually be the most healthy that you could be? There's probably going to be a need for a little bit extra protein, which I've got there, and a bit more fiber and a bit more water. And women really don't drink enough water because they already increase the amount of time that they go to the toilet just by the changes of their body to pregnancy. And so it's an inconvenience to have to go to the toilet all the time, but certainly they shouldn't be dehydrating themselves just to reduce that inconvenience. And in terms of supplements, ideally folate and iodine start before you're pregnant, because the folate is most important for the neural tube as well. And as I said, sometimes that's formed before you know you're pregnant. So any women intending on becoming pregnant should definitely be on a folate and an iodine supplement. In terms of iron, this is something that you really should monitor in athletes, because you need 30 milligrams a day if you've got normal iron stores, which is reasonable to get in your daily food intake. But you need up to about 100 to 120 as a supplement if you're iron deficient in pregnancy, because your fetus will just leach the iron from your body. But those multivitamins, often people say, oh yeah, I take iron in my multivitamin. They often have about 5 milligrams of iron. So you have to be careful that people don't think they're taking iron when they're not, especially anyone who's on a vegetarian or a vegan diet. And calcium and vitamin D are important because your bones will be leached to support your fetus. And just being aware that calcium and iron don't go well together. So if you're taking both those supplements, the calcium will reduce the absorption of the iron, so they need to be taken at the other ends of the day. So musculoskeletal considerations during exercise, and we'll go into this more in the postpartum period, but these things do occur in pregnancy as well. And if they're happening in pregnancy, odds are they're going to happen in the postpartum period, except for probably the only one caveat to that is the low back and pelvic girdle pain. That often does go away just by having the baby and getting some space back. But a lot of them do hang around, and we'll go into each of these in more detail. So in terms of the pelvic floor, I think that it's really important to distinguish between common and normal. And I harp on about this a lot to my patients, that just because something is common doesn't mean it's normal. So we hear all of these things about, oh, well, I'm pregnant, so that's why I'm just leaking a little bit, or it's okay because that's to be expected, and when I have the baby, it'll go away. Like, absolutely not. Women should not put up with any of these symptoms, and they should certainly seek help from someone during the pregnancy, because it's not just a matter of, oh, I do my pelvic floor exercises, so I'll be fine later. It's a matter of how are you doing those pelvic floor exercises? Are they adequate contractions? Are you over contracting and so you're wearing out the muscles and you're not actually switching them off ever? So yeah, in Australia we have women's health specific physiotherapists, and I assume you have a similar thing over there, and they're absolutely worth their weight in gold. In terms of prolapse, if you look, I don't know if you can see my pointer here, but if this is a normal anatomy, and so you can see that the uterus here is stuck right between the bowel and the bladder. And with prolapse, what happens is that after childbirth, the uterus is floppy and it sort of sinks down, and so the inside of the uterus can come into the vaginal wall, or you can get one wall prolapsing, either the posterior wall from the bowel or the anterior bladder wall. And again, prolapse is not something that it's a common thing, and people often say, oh yeah, that's just because I've had a baby and it'll spring back out into shape soon, but it won't. You need to. And if you're having prolapse during pregnancy, the women should not be doing load weight bearing exercise in standing. They should be making sure they have lots of supine rest scattered throughout the day, and consider exercise in side lying and lying and things like that. So this is often what they'll feel. Most women don't really know they've got a prolapse because they're not very well aware of what's happening to their body, and sometimes they don't know it's there until they look in the mirror and see something that shouldn't be there. But certainly we just need to be more open with conversations about prolapse. It's certainly not something to be ashamed of, and it's not something that the women have done anything wrong to have it. It's just a natural fact of some pregnancies. With low back and pelvic girdle pain, this is just to show you that it can occur anywhere. So you can have pain anywhere in your body, and it's not specific to necessarily the site below it. Often though, in pregnancy and in the postpartum period, it's aggravated more by split leg movements and prolonged sitting and standing and rolling over. Certainly for me, I'm a restless sleeper anyway, but the thought of rolling from one side to the other when I was pregnant, it still gives me shivers now thinking about the pain in my pubic symphysis, just adjusting my position. So things like putting pillows between your legs, propping yourself up with pillows, doing all your movements with the double legs, so doing the same thing with your legs at the same time, that definitely helped me. I felt fantastic squatting, but I couldn't lunge pain-free for a whole year after having my first child because of my pubic symphysis pain. So it doesn't mean, oh, pain, stop exercising, and it certainly shouldn't be pain, push through it, but modifications to think about, and every woman is individual and different, so you have to be a little bit creative. So as I said, consider exercises. A lot of this band here on the right, this sacral band, they're very helpful. It's like you Velcro it together, and then it's got a double layer that stretches out. You should wear it compressed as much as you can press below the belly, so over the iliac crest is where it should be worn. And interestingly, they make them for SIJ dysfunction, and I tried it in my second pregnancy and I got horrendous pubic symphysis pain because it was stabilizing the back and pulling open my pubic symphysis. And then my very wise women's physiotherapist colleague said to me, why don't you put it on backwards? So, and that really helped. So again, there's things that you can think of, but then you've got to be very creative and think outside the square, because every single woman is different, and every woman is different from one pregnancy to the other. So that's being active in pregnancy in a nutshell. And now we're going to move on to after the postpartum period. And a lot of the things are we've touched on them already, but we'll just go into more details now that the baby's been born, and we don't have to worry about the effects of the baby so much. It's all about protecting our own bodies and making us as physically strong and healthy as quickly as possible. So with the pelvic floor, a lot of people think about we talk about the core all the time. It's very in vogue, the core now, but I think that a lot of people think that the core is synonymous with the abdominals, and it absolutely isn't. There's 4 layers of abdominal muscle, as you would know: the rectus abdominis, the 2 layers of obliques, and then the transverse abdominis. And really the transverse abdominis is 1/4 of the core. And the way that I explain this to my patients is, if you have a cardboard box and you're carrying it and it's a stiff, strong cardboard box, then you can probably just carry it with one hand underneath, or you could probably hug it into your body with one arm and nothing would happen. And if it was full of rocks, the rocks wouldn't fall out. If you get a cardboard box that's saturated with water and you try and carry it one-handed, everything's going to collapse around you and the rocks are going to fall out. And if you just carry it with the front and the back, then the bottom will fall out and the rocks will fall out. And so thinking about the pelvic floor as a sort of a box with the transverse abdominis at the front, the pelvic floor on the bottom, the multifidus, which is the deepest extensor muscle at the back, and the diaphragm at the top. And you need to really keep that nice and strong and contracted well. So if we do a maximal contraction with our abdominals at the front and none of the other three turn on, then that's actually not doing very much to help keep everything inside at all. And so on the right here, you can see that if you're breathing easily and you're contracting these muscles, then the arrows are showing the way the muscles should just draw in slightly. But if you do a breath hold and you contract maximally at the front here, what's going to happen is you're going to push down on the pelvic floor and you're actually going to lead to more incontinence type symptoms and prolapse symptoms than you are if you didn't do anything at all. So that's really, really important, is for all of the women to understand what a core contraction is, to understand how to use it adequately. And most people I see, whether they're pregnant, postpartum, or just athletes or just anybody, they don't know how to voluntarily activate their core properly, and what they think is their core is about 500 other muscles that are just contracting too hard and unnecessarily. So this is basically what I've told you about, that if we look more now at the pelvic floor part of the core, the muscles are designed to be low-level constant contraction. So they should be about 10% of a maximum voluntary contraction. They should be able to hold that for most of the day, except when we want to adjust before and during urination. So that's the whole idea of them. And in an ideal world, that's what happens. We should also be able to intentionally contract them and lift, and so it should be a lift and squeeze. The women's health physiotherapist that I work with has a great analogy to explain this to women. She said, if you drop a pebble, if you think of a pebble dropping in the middle of your pelvic floor, but the pelvic floor was the water, the pebble would drop and the ripples would spread out from there. So a pelvic floor contraction should bring those ripples back into the center, and then the pebble should lift back up. So women visualizing this are more likely to use a pelvic floor contraction the way that it should be performed. So there's been lots of studies where women have just been told, okay, contract your pelvic floor, and about a third of women contracted the wrong muscles, and they were, well removed from the pelvis, groin, the abdominals, gluteals. And then so then if you take the 2/3 that did the right muscles, a quarter of those women performed a strain instead of a lift, so a lift and squeeze, so it was more pushing down. And then if you take those out, only half could perform an adequate contraction that was strong enough to actually close off the urethra. So there's a lot more to be done in this space than just say squeeze and hold. So if we move on to, thinking about exercise, you've had your baby, and then you're just thinking, okay, it's eat, feed, sleep, repeat, and probably not much of sleeping. And I want to get back to some exercise. Then again, I mean, this is probably the broadest spectrum of women you can ever find. So women who have had vaginal deliveries versus cesarean deliveries are going to have lots of different problems or complications or things to think about. Then within the vaginal delivery, is it an unassisted delivery? Is it vacuum? Is it forceps? Did you need an episiotomy? So that's where the pelvic floor is actually cut by the obstetrician or the midwife, because they can see that the head is going to be too large, and if you perform the cut before there's a tear, then it's less likely to tear in places that you don't want it to tear or to be too big. And so therefore, if you have an episiotomy, you need stitches. And some women need stitches because they've had a tear that was unforeseen initially. Then there's whether you've had postpartum bleeding, how much bleeding you've had, how much iron have you lost, how much blood have you lost, how much sleep are you getting? Some women have these babies that just perform for them. Other women, like myself, have a child that doesn't sleep for 4 years. So it's very different, and it depends on whether, what your situation, what their situation is, as to what you can do with them. And then there's the things that are like that we spoke about before, these complications of pregnancy, do they still exist? And a lot of women think, oh yeah, it's like my pelvis is there, but that's okay, I've just had a baby, it'll get better. And this is the most important time to address these things. And then additionally to that, if the woman's breastfeeding, that's another thing to add in. So I'm not exactly sure in the US how it works, but in Australia, we have the private and the public system. So if you're in the public system, you go into the public hospital and you have the midwife who's on call at the time that you're in labour, and you just follow up in a midwife clinic 6 weeks after birth. And really it's a, hi, how you going? Yes, your baby's alive. It looks like you're well dressed. You've got out of the house. You don't have postpartum depression. You're doing very well. Do you have any issues? No. Okay. see you later. If you're in the private system, you have your own obstetrician, and they follow you through, and you follow up with them at 6 weeks. But again, the 6-week follow-up, there's no examination involved in Australia. It's more of a chat to see how you're going and if you've got any problems. And so certainly there's this sort of notion in Australia that, oh, I've got my 6-week clearance for my obstetrician or my midwife, and so I can go back to exercise. But in reality, like, what is 6 weeks timing, and what is that clearance? And so this is just a slide to remind us that if we have an operation, we have an orthopedic operation. If you think about an ACL repair, we've got, you know, really beautiful, strict protocols about what you should do post-operatively, and you've got to tick these things off before you move to the next phase, and it's all very well spelt out. And then in, you know, post-pregnancy, it's okay, you know, you shouldn't really be doing anything before 6 weeks because you've just gone through a major trauma and you've got a new baby. And then 6 weeks, oh, yep, you're fine, go and do everything. And I love this slide because it does put into, you know, very clear what the issues with the getting back to activity postpartum are. I think the other thing is, so in Australia, we have women's health physiotherapists that do a very thorough postpartum check at the 6-week mark, including a digital exam to see how the pelvic floor is functioning. This is certainly not something that's a mandatory thing, and it's not something that's even part of the normal thing. But in any of my athletes, I 100% say that's the first thing that you should have done, because how do you know whether a muscle's working properly if you don't assess it? And how can you assess it based on saying, yes, I can squeeze it, or no, I can't? So I think that's really important. The next thing that I notice is that women always think that they shouldn't go back to strength training because, oh, I know my body's not ready to lift heavy loads, yet they'll lift their other children, they'll do all of their activities of daily living. And there's a good YouTube clip on this where a lady carries a heavy medicine ball around for the day like it's a baby, and she lifts it and she wipes it, puts nappies on it and wraps it up and rocks it to sleep. And it actually does make light of the fact that, you know, even your baby's heavy. And so why shouldn't you strength train to get stronger at being able to hold and support your child? So on the left here, well, this is front squats. So I'll play, this is me here, I'm playing my one. This was 2 weeks after I had my daughter. I'm a terrible squatter anyway, but you can see how much extensor strength here I've lost. So the problem with pregnancy is that you get this big thing at the front here that props up your back. So you don't actually need extensor strength. So you actually lose a lot of lumbar and thoracic spine extension strength. And then you can see at the bottom of my squat, my pelvis is dipping. This is a very bad squat. But it's just there to show that you have to start somewhere. And the benefit of front squats, so having the barbell in the front rack position, is that it will naturally activate your core. You just focus on pushing your knees out for your glutes and pushing your elbows up, and your core will turn on. And certainly for me at this point in time, this is very early, it activated my pelvic floor for me, and I felt wonderful. If I was to press that barbell above my head, then I felt that I was pushing down on my pelvic floor, and that felt awful. So I didn't do pressing above my head for a very long time after pregnancy, but I kept squatting because it was a better way for me to activate my pelvic floor, but very light squatting than what was beforehand. And so just to show you how you should, sorry about the music in the background, to should squat. So this is me last week. So as I said, I'm not a very good squatter in terms of I'm very stiff in the hips, but you can see there that I've got a lot more extensor strength and my pelvis isn't dipping at all. And so that's what you're aiming for, but you start light and work towards that. And then over here, this is my sister, the one that had the baby 8 weeks ago. So I just want to show two things here. This is the 15-kilo bar, and this is her 6 weeks after birth. And you can see that she dips forward. She doesn't have enough strength up here to hold her body upright. But this is on the same day here with 25 kilos on the bar, and she actually does a better job. So sometimes you do need a little bit of load to kind of figure out what you're trying to push against. But she would have been squatting up to 50 to 60 kilos in pregnancy, and her 1RM would be 80 kilos. So 25 is not heavy for her. It might be that the 15-kilo barbell is heavy for a woman, and therefore you'd be doing something with a broomstick and then progressing to a barbell. It's all very individualized. So to return to running, you actually need time for recovery of all the tissues. Childbirth is like a trauma. And then also you should, in all my athletes, I say you have to have strength. You have to be moving. I'm not letting my sister go back to running yet till that squat looks normal at a reasonable load. Because if you do that, it gets you back so much better, and it'll get you running and playing sport quicker in the long run. So things that we've spoken about a lot already, they're obviously the barriers to coming back to activity. So if a woman has no pelvic floor disorders, pain, no diastasis afterwards, then yeah, she can start it, whenever she's been assessed by the physiotherapist to tell her that her pelvic floor is functioning normally, and just progress as normal, like you would anyone coming back to load after a rest. But these things are common. And so the thing about prolapse is that women just want to kind of push on with it. So it's, half the women will have some degree of loss of support, and people think, I'll push on, and then I get it operated on. Like, absolutely, there is no way I would have an operation on this. There's actually a lot of lawsuits in Australia at the moment. People have been having mesh put in it's turned into chronic pain for these women. They can't get the mesh taken out because it's integrated into their soft tissues. And if half of the people who are having surgery are having reoccurrence, and then a third of them are having another surgery, I just don't think that surgery is just something we should think about at all. And there's increased risk with increased operational delivery in terms of vaginal delivery for prolapse. And so things are definitely, this is one condition where if the woman can feel that she's feeling her prolapse, then she doesn't push through, and she actually has to put lying down time in to her routine. But also because the pelvic floor is a muscle, so it gets fatigued. So I noticed when I came back from training to skipping, if I had, say, 10, I'd do double unders, I could do little short bursts of skips with no problem. But if I was to do 100 all in one go, my pelvic floor would get fatigued. And so it is a muscle, and it does need to build up endurance and strength, just like any other muscle. And the same thing with incontinence. This is something that people just think, oh yeah, well, I just had a baby, so it's normal for me to leak urine when I'm training because I just was pregnant and I've just gone through childbirth. And although it is common, so 28% in all sports, and interestingly, 85% of trampolinists, and this was even in 16-year-olds were included in these studies, and 65% of gymnasts, and these are elite athletes that haven't been pregnant yet. So it's a common thing, but it doesn't mean that it's normal. And so you can see that it becomes more common the more children you've had. And I think that the most important thing here is that if you have these symptoms at 3 months and you do nothing and wait for it to get better, odds are it's not going to get better and it's going to last 4 years. And it's a lot harder to address something at 5 years than it is to address something at 3 months. And this is Diane Lee, is a phenomenal, she's a Canadian physiotherapist and a phenomenal source of resource for all things pelvic floor, core, rectus abdominis. And I love this quote from her: all urinary incontinence should be investigated and not celebrated. And this was on the back of, there was a movement a little while ago in CrossFit, I think it was, where people were putting up videos of puddles of urine on the floor and saying, well, look how hardcore I am. I keep exercising even though I'm wetting myself. And I think that that's a terrible message to send. And so again, we try and do exercise, but exercise is in rehab, not just going to train. Women's health physiotherapists are trained to do this, and it's not just strengthening, it's coordination. And the good thing about pelvic floor muscle retraining is that it can be a very good preventer as well as a treatment, and it's really it does this before, during, or after pregnancy. I've got down there the pessary support. Sometimes women need, and that's where something's inserted into the vagina to give the vaginal wall more support to stop a prolapse or just to give the urethra support. And again, these are really important in some athletes that might need to use it, but it's not, oh, I'll just use a pessary instead and I'll get back to running quicker. That's definitely not how it should be used. So we all probably know this, but in studies, it's a long-term commitment. It's 15 to 20 weeks of training, 2 to 3 times per day for 3 to 4 days per week. So it's, these women are committing to feeding their children 6 to 7 times a day in a 24-hour period. So they should be easily able to commit to this, but a lot of women will put their child first and not themselves. So this is something you really have to reiterate, that it's not just, oh, every time I think of it, I just do some pelvic floors. It's a committed exercise rehab program. So in terms of pain, as I said, this is probably one that does settle after pregnancy somewhat. So the 90% of women, so women who have had pain in their pregnancy won't have the pain after pregnancy. So sometimes just having the baby does help, but a lot of the time it doesn't. And if you've got that pain postpartum, it will not go away. And what happens is you start to make musculoskeletal compensations for the pain, and it can lead to lots of different issues down the track when you're trying to get back to sport or recreation. In terms of abdominal separation, I think this is another one that's really in vogue at the moment. And I think the most important thing I wanted to highlight is that the connective tissue in here in the middle, the linea alba, it's designed to stretch. So it's not a complication that's something that's like, oh my goodness, why is this happening? If it didn't stretch widthwise, then the muscles would detach from either the pubic symphysis or the sternum. So it's a natural thing. And the other thing to think of is that the linea alba, the connective tissue, just gets thinner and stretches. So if you think about bubble gum or chewing gum and you pull it out of your mouth and you stretch it out, but it's still intact, that's what happens for the most part. But I think a lot of women think there's this big gaping hole in the middle of their abdomen, and that everything's going to be disastrous from that point forward. So this is my women's health physiotherapist colleague, and this slide is just to point out, so this is us before pregnancy, and this is us at 40 weeks pregnant. And the way that we carried our children, like she's petite, she's tiny, I'm not tiny. And you can see the way that we carried she basically just carried it all out in front, whereas I feel like my child was wrapped around my back. So you can see that the effect on our abdominals is going to be very different. So this is her after pregnancy. The ones in the plain shorts are lying flat. I think this was very early post-pregnancy, and then doing an abdominal crunch here. And this is the classic erectus diastasis look. So that kind of dimply skin. Lots of women think they've got it. If you don't have this dimply skin, or they don't have this dimply skin, they probably don't have it. They probably just got weak abdominal muscles. This is her 18 months later. So much closed off, but still you can see the effects of it. But when she crunches, she's not doming at all. And so the whole thing about abdominal separation is the function of the abdominals, not the look of them. So that separation will spontaneously close from day 1 postpartum to 8 weeks, but anything that's there at 8 weeks is probably likely to be there at 1 year. And I think the most important thing to think about in this thing is there's no like, oh, these are rectus diastasis safe exercises and these ones aren't, and that just because you're using your abdominals doesn't mean it's bad, because it's not about the size of the gap, it's about the function. And a lot of people, when they engage their abdominal muscles, the gap actually closes and it functions well, and there's no doming of the abdominal contents. So you can see here that you can see her gap quite clearly, but as long as her abdominal contents don't push out the middle of it, and that's very obvious, like you'll know straight away if that's happening, then it's probably fine. But I think the things to think about are, if woman isn't progressing, there's probably something else going on as well with pelvic floor. And some women, this is the one time where I would say that some women do end up needing surgery, not a lot, because if you don't have that, as like if you think back to that cardboard box analogy, if you don't have the front wall of the box, how can you, and it's dripping wet, how can you possibly support that? And again, Diane Lee, she's got wonderful resources. You can just Google her and find her website. This was an accident. I was meant to be filming my squats, and this was my break in between, except that I filmed the break and not the squats. And my children both have severe reflux, and this is just to show that, you know, it's all very glamorous on Instagram, they're training after your baby, but the realities of it are that you've got a baby that you've got to manage as well, and any bit of exercise is better than no bit of exercise. And the things to think about is definitely fluid intake, calorie intake, and the breast, like if you're breastfeeding, think about practicalities of breastfeeding. But it's not dangerous to exercise. There's a myth that, you know, oh, my milk will dry up if I exercise too hard. Absolutely not. As long as you support enough, you eat enough calories to support milk production and exercise, then it will be completely fine. The composition and the amount of milk will not be affected. And it's fine to breastfeed straight after a workout, but there will be lactic acid in the breast milk, because whatever's in your blood is in your breast milk. So if you drink alcohol, the alcohol's in the breast milk. If you exercise, then the lactic acid's in the breast milk, but it will go away again. So if the woman's baby is happy to feed on that, there's not harmful at all. But if they get a bit fussy and don't like to, then expressing before feeding and feeding with a bottle afterwards is an option, or just timing your training around the baby's feeds is also an option. So this is a shameless plug of my website that you can find, and just to let you know that I actually do telehealth consulting. So if you click on the book now session, there's actually a service for people outside Australia, and I do pregnancy and postpartum reviews for women who are trying to get to exercise but might have some barriers or complications, or just might not feel like they're a bit anxious about doing it, or they need help kind of working out how to fit in their life. Then that's certainly something that can help. And just to show you, this is my sister 3 days before she had her baby, and although your center of gravity does change, it certainly doesn't mean that you can't do weird and wonderful things if you're skilled at doing them before you fell pregnant. So thanks very much for listening, and I'll be happy to answer any questions.
All right, thank you very much. And we've got a couple questions here. We'll briefly head through those. So the first question comes from Christina, and she's asking about looking at heart rate thresholds in pregnant women. Should we put a maximum heart rate? Should we how should we address heart rate thresholds during pregnancy?
Yeah, so that's a good question, and I think this is like pregnant women are going to ask this all the time, and especially now with iWatches and other Garmin's and Fitbits, where they're literally constantly monitoring their heart rate. I think that it's actually better to use rate of perceived exertion, so the Borg scale, rather than the heart rate itself. And there also is there's some good tools in terms of looking at the heart rate. So in that the Canadian guidelines that I included, and sorry to not include the American guidelines, but the Canadian ones are the most up to date, although it's wonderful that all of the world actually have the same guidelines. It's probably the only thing that we agree on across the world, so that's fantastic. But in that reference, the 2019 guidelines, on one of the pages, there's the heart rate ranges for pregnant women that match the intensity ranges. And so if you have someone who's really fixed on heart rate, then that gives you a bit of a guide, because the heart rate will be higher for any given workout intensity. But in all honesty, I never use heart rate to monitor exertion or intensity, because as I said, the fitter the athlete, the higher the heart rate's going to be. So what you're going to do is you're going to actually find that the heart rate gets really high quickly, and they'll actually not be able to do much exercise. I think heart rate's better used in terms of recovery time. So what you want to monitor, and again with the watches, you've got wonderful feedback here, monitor how quickly the heart rate comes back to normal. So if the woman is exercising with an elevated heart rate and that heart rate stays elevated for minutes afterwards, like 10 minutes later, and it's still really high, that was probably way too intense. But if their heart rate goes right up where they're exercising and then it comes right down as soon as they rest, then that's a really normal response to activity, and that's fine to keep going at that threshold. And really, if she can still talk to you while she's exercising, she's not going too intensely.
All right, the next question comes from Erica. She's asking, if you live in high altitudes, getting back to the altitude discussion, if you live in high altitudes, are there features that you should watch for, symptoms that you should watch for? Are there, what should be the limitations from an altitude perspective if you live there?
Yeah, certainly. That's another good question. So in terms of altitude, it's all about the binding of oxygen to the hemoglobin in the red blood cells. So if you live at altitude, then you're already going to have favorable types of hemoglobin, and you're going to have more hemoglobin to start with. And so you're already adapted to altitude. And so in terms of that, then it's the same as if you were at, you can consider that your sea level. And so what you're looking out for is just looking at intensity of exercise in terms of your respiratory system and your cardiovascular system, and making sure that when you're exercising, you're not feeling really unduly breathless or lightheaded or dizzy. So all of those symptoms that would mean that you probably should take it a bit more easily. But as I said, I climbed to 2,500 meters altitude when I was pregnant, and I certainly felt my heart rate, but I didn't feel different to sea level. And I think that if you live at altitude, you'll notice even less of a difference.
Perfect. So the next question comes from Mel. She's asking about the suggested caloric intake during pregnancy with activity. How should that change? And I do think you might have touched on that a little bit.
Yeah. So it should definitely increase. And And yeah, one of the slides which you'll have access to actually gives the guidelines for that. So that the guidelines that I've given are increase guidelines. So if you take the baseline calorie intake, which is, I mean, I talk in kilojoules, in calories, I'm not sure which units you guys are most comfortable with, but if you've got someone on, say, a 2,000 calorie per day diet, then you need to go up another 300 to 400 on top of that in the first trimester, and about 1,200 on top of that in the second, and 1,900 on top of that. So it's actually quite significant. Like, if you think about it, you're meant to be eating double by the end, which is almost impossible. But I think that those guidelines are just to show women that they actually need to consider this activity and physical activity itself. Growing a baby is like your body is being physically active. And so, and then in terms of practicalities, small frequent meals is far easier than big large meals. And so women should just eat when they're hungry, but you should find nutrient and energy dense foods so that you can have smaller amounts of food with more nutrients and energy packed in. I think that's the most important thing.
Awesome. Well, certainly a very appropriate and timely discussion, considering we have so many elite and professional female athletes who are currently choosing to have pregnancy as well as continuing their athletic careers. And so I'd like to thank you, Dr. Cole, for an excellent presentation, and thank you to the many people who joined us tonight. And I hope that Wednesday in Australia, I hope that we have just as good of a Wednesday here in the United States.
Yes, so do I. Thanks for having me. It's been very fun.
Indeed. All right. Have a great night or afternoon or morning wherever you are.